Hello, welcome to the presentation on antidepressant drugs. This is Julian's Chapter 12. I'm Dr. Audrey Robinson. No, I'm not that kind of doctor. I have a Ph.D. in counseling, and I am teaching counseling psychopharmacology for Texas A&M University Commerce. There's my email if you have questions. All right, so as always, I start my lectures with this. Why in counseling classes are we learning about antidepressant drugs? These meds have been around 65 years. They're commonly prescribed. There's lots of side effects. And honestly, there's only limited efficacy versus placebo in mild and moderate depression. These are all things that it is important to keep in mind when our clients come to us and we find out that they are taking medications, knowing what the side effects might be, not giving any kind of a medical advice, but being able to advocate for our clients and support them with these medications. All right, so let's talk about depression. It's often chronic, recurring, and can be potentially life-threatening in the form of suicide. It's an affective disorder. There are changes in mood and emotion, which are the hallmarks of depression. It is common in 16 million adults yearly diagnosed, often more women than men. Only a third of those who are screened and found to be, having depression, positive for depression, actually get treatment. That is profound. Only a third of people diagnosed get treatment. There's this new theory out there, a new school, saying that it is a neurogenic theory of depression. It's a myth that this is a chemical imbalance. We used to think that, but now we know so much more about our brains and our bodies. Major depressive disorder is the leading cause of disability worldwide. That neurogenic theory says that our brains can actually repair. We can repair and remodel neurons, and we can even grow new ones. Our brains are much more plastic than we thought they were. We thought it was pretty fixed, that you were born with everything you were ever going to have, and that your brain and cells and neurons and things slowly died over time, and you never got any new ones. That is actually not true. Our brains can grow and change. So now we see this as a neurodegenerative disorder with those neurons. We're now looking into the second messenger systems when we're looking at depressions, and it's important to keep in mind that there is a genetic component. All right, so we're going to talk about first generation antidepressants, and there are different categories under this class, and those are delineated in the red text. So first, let's talk about tricyclic antidepressants, and I just abbreviate that as ADs through here rather than writing that out every time. So this class gets its name from a 3-ring molecular core that it has the effect on. This includes anxiolytic properties and analgesic actions. Examples of these are imipramine, desimipramine, amitriptyline, and nortriptyline. These are still prescribed somewhat, although they're not as common with some of the improvements with the second generation. The way these work is they block presynaptic reuptake transporter for norepinephrine and serotonin. So there's a dual action with this class of medications that we'll also see in some of the second generation. It also blocks postsynaptic receptors for histamine and acetylcholine. And that second action is where the side effects occur. Things like drowsiness and sedation from the blocking of the histamine, and then the blocking of acetylcholine leads to confusion, memory and cognitive impairments, dry mouth, blurred vision, increased heart rate, constipation, and urinary retention. Doesn't that sound like so much fun with those? That is one of the main reasons that these are not used as frequently anymore. For pharmacokinetics, they're really well absorbed orally. They have relatively long half-lives, and so they're often utilized at bedtime, given as directed to take at night because of that drowsiness. These are metabolized in the liver, and they often have up to 4 days effect or even longer in elderly. And it's important to know that if you're working with elderly populations and you have anybody on these TCAs, as they're often abbreviated, that those side effects and the longer acting up to 4 days or longer, they can have even more of those cognitive impairments. Elderly are affected much more with the blurred vision, confusion, memory, and so that might be something to keep in mind if you're seeing that in some of your clients. Pharmacological effects. They have 3 clinical effects. They are slow onset of action. There's a wide variety of action on the central nervous systems and many adverse side effects. Overdose is potentially fatal via cardiotoxic actions, and that overdose would be if somebody tries to use TCAs to complete suicide. They also block alpha adrenergic receptors, which leads to dilation and drop in blood pressure. So the next one is MAOIs, and if you watched the last PowerPoint presentation, which if you're taking this class, hopefully you did, I mentioned MAOIs and how they interact with everything. If you listen to any pharmaceutical commercial, they say, do not take if you're taking MAOIs. And if you get many over-the-counter medications, they specifically mention MAOIs. So that's a monoamine oxidase inhibitor. They work differently than TCAs through the buildup of neurotransmitters, specifically norepinephrine, dopamine, and serotonin molecules in the terminal. But they have serious and often fatal side effects, and they have many, many interactions. From the time I worked in pharmacy for 6 years as a pharmacy technician, many of the pharmacy programs look at the medications that a patient is currently taking, and so when you put in a new medication, a new prescription, and go to fill it, it checks against what the patient already has on file and in the system for that they're already taking, and so it looks for contraindications and drug interactions, and so this pops up as like a bright red flashing like warning because of the potentially fatal side effects. This is also one reason that is really important not to pharmacy hop just to get the best price or to get a coupon or something like that, because if you're filling different prescriptions at different pharmacies, then pharmacists and the computer systems can't do what they are designed to do because they don't know the other things you're taking. So it's really important for a standard of care to be careful. These MAOIs are effective with atypical depression. Then there's other heterocyclic ADs. These are really not very, very commonly used. It's not the first choice due to side effects. One example is clomipramine. It's a mixed serotonin and norepinephrine reuptake inhibitor. It's got that dual action. It's often used to treat OCD with 40 to 70% efficacy, but it has similar side effects to these TCAs, which is one of the reasons it's not used. Bupropion is another one. It's used for kids with ADHD, but honestly, it's not been proven to be very effective. And it's also marketed under a different brand name for smoking cessation. There's also been some look into how psychostimulants, things like ADHD type medications, work for antidepressant, and it has shown to have good results when you use those psychostimulants in combination with second generation antidepressants. So bupropion, we were talking about that heterocyclic antidepressant, is a weak reuptake inhibitor of the neurotransmitters, but it works kind of like these psychostimulants, but without having the side effects of the availability for abuse of those, because those are controlled substances. It doesn't have any effect on serotonin, so it doesn't have as many side effects, which makes it somewhat appealing, although its side effects include anxiety, restlessness, tremors, insomnias, and often seizures. Now on to second generation antidepressants. Again, delineated in red are the different types that fall under this second generation. So you've got SSRIs, SNRIs, SARIs, NASA, and atypical antidepressants. Let's start with SSRIs. These are really incredibly common. They work by blocking the presynaptic transporter for serotonin reuptake. They don't have any effect on that postsynaptic, which is where you see some of the less side effects, but also some differences in efficacy. Their side effects include insomnia, anxiety, agitation, sexual dysfunction, which is one of the major ones that are reported as a not favorable side effect. They also have been shown to have increased suicidality, especially in pediatric and adolescent cases. And so when that was kind of discovered, they put a warning on these, a warning label that has to be printed and placed on on the medication bottle in the pharmacy, and that led to a decrease in prescribing these, which actually led to an increase in suicide, because we know when depression isn't treated, many times it leads to suicide. So they kind of, pendulum swung one way, and then to compensate, it swung back the other way, which led to more suicides. It also can have a side effect of apathy. Some example names of these would be citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. And those are all the generic names, because sometimes these are marketed under many brand names, but these would be things like Lexapro and Paxil, and some of those very common ones have been around a while. So SSRIs are not fatal in overdose, which is why they're not as effective also. And overdose of these can lead to this serotonin syndrome, which is cognitive disturbances like disorientation, confusion, hypomania, behavioral agitation and restlessness, autonomic nervous system dysfunctions, which would be things like fever, shivering, chills, sweating, diarrhea, hypertension, and myoclonus, visual hallucinations. And so serotonin syndrome can be brought on not just by SSRIs, but on other drugs that work on serotonin or that mirror serotonin. So I know, like, I have migraines, and so I was taking a migraine medication for a while, and I had to stop taking it because it had the potential for the serotonin syndrome in conjunction with the antidepressant I was taking at the time. Treatment-resistant patients may fail to respond due to ineffective dose or ineffective length of treatment. And if they're a rapid metabolizer, they may not respond as well to these. So when you discontinue SSRIs, you can get what's considered a discontinuation syndrome, which has like flu-like symptoms, insomnia, nausea, imbalance, sensory issues, hyperarousal. So it's really important when you're working with a patient, with a client, and they are taking some of these medications, if you hear them saying like, I don't like how I feel, these side effects are terrible, I'm just going to stop taking it, you can give them some information and say, hey, that's something you need to talk to your prescriber about before you do anything like that. I know that there are often syndrome side effects that come when you quit these cold turkey. That's why many times patients are dosed up and dosed down when they're starting these medications. Another group is the SNRIs, and so it works on serotonin and norepinephrine. And really, those tricyclic antidepressants, the TCAs, are the original dual action, but these were created to either improve or maintain efficacy while trying to limit those side effects. And then you've got some examples: venlafaxine, desvenlafaxine, duloxetine, which is Cymbalta, and I'm not even going to try to pronounce that last one because I've got no clue. A lot of times when you see drug names that are very similar, like here, venlafaxine and desvenlafaxine, and under the SSRIs, there's citalopram and escitalopram. When you see like a different prefix in front of that same drug name, it usually means that they take the active process, the active ingredients of that, and they make it even more active without the other side processes that go into that, so that you're taking something and where you might need 20 milligrams of citalopram to reach efficacy and to have subsiding of depression, you might only need 10 milligrams of escitalopram because you're literally taking the most active parts of that. Fun facts on that. Okay, you also have SARIs, which are serotonin 2 agonists and reuptake inhibitors. So what those are is they have dual action again, and they're similar, kind of related to trazodone, but a lot of differences. They're really not prescribed very much because they can produce liver failure, so it's just noted in there because they can still be got in the generic in the US, but the brand names of those have been discontinued in the United States and Europe. One more thing I wanted to mention about many of these antidepressants is you have what's called antidepressant tachyphylaxis, aka poop out syndrome. And so what that is where these seem to lose effectiveness, and we're not exactly sure why that happens, if there's like people become used to them, if there's changes in absorption or what. We're not really sure why, and so there's lots of different things they try to help with that. There might be like a brief vacation from the medication. Sometimes they try increasing the dose. Sometimes they change the class of medication to help with that when they're suddenly not as effective as they were before. All right, and then we have NASA, which these are noradrenergic specific serotonin antidepressants. They don't have any side effects like SSRIs, but drowsiness is heavy and very potent, and that they're often, you can't use them in conjunction with alcohol or anything else that would cause drowsiness. And there's high amounts of weight gain. So the main one of these is mirtazapine, and it's really not prescribed very often. Then you've got these atypical antidepressants. So it's dual serotonin action with that pre and post synaptic. And really, there's no therapeutic advantage over any of the older drugs, and there's often some different side effects. So these are really not often used very much, but it's important to know that they're out there. All right, let's talk about complementary and alternative medicine. These get thrown out a lot, and one of my pet peeves in medication is when somebody who is not a physician and really doesn't know much or anything at all about these read some article or had a friend who tried this and it worked for them, and they say, oh, well, if you just take St. John's wort or folate or omega-3 fatty acids, that'll cure your depression. There's all these myths out there that surround antidepressants and depression, and so we're going to kind of talk about some of the actual science with this. Folate is a B vitamin, and it enhances the production of monoamines and those neurotransmitters that we've been talking about: serotonin, dopamine, norepinephrine. It can be used with SSRIs, and it has some efficacy when it's used with those. They also saw some improvement, because people sometimes have deficiencies in B vitamins, and often in D vitamins looks very similar to this. So no, it is not a cure for depression. No, it is not an effective help with treating depression, but sometimes can be used along with it with antidepressants. Then you've got omega-3 fatty acids. Really, the benefit has only been seen in conjunction with antidepressants. It is good for us. It has neuroprotective action, so people can feel better in other ways too. And then this I don't know how to pronounce that. Possible efficacy in helping only with mild depression, has not been seen to be helpful with anything severe. And then you've got St. John's wort, which is probably one of the ones you're familiar with, and I've heard this thrown around a lot. Well, I'm just going to give my kid St. John's wort, or you should just try taking St. John's wort. Most studies that shown to have efficacy, there was huge bias in those, so those really studies should be thrown out. This should not be combined with SSRIs due to producing serotonin syndrome. So when people are telling other people, just take St. John's wort, it actually can be very dangerous. St. John's wort can also increase absorption of other certain medications, making them toxic. So St. John's wort also has a ton of side effects. So this is something that, wants to be used with caution and really should be used under the care of a physician if you're taking any other medications, including over-the-counter medications. Alright, I know if you watched the last video, I talked about GeneSight, and I swear that I'm not working for their company or anything, but this is something that I have used personally in my search for finding the best antidepressant that helps with my depression and anxiety. And so I really kind of wanted to show you again this top part that shows the drugs that you can use as directed. There's a moderate gene interaction and then a significant gene interaction. And what I didn't include last time was this bottom clinical consideration. So it shows you some of the things we've talked about, here are the things to concern, these 1 through 8 that are listed next to the medication. So one of those that we talked about was the absorption, how slow or fast you absorb certain things. And that is one of the things that is listed here, if you go and read further down in the report, that serum levels may be too low in smokers is one of the things, and use of this drug may be increased risk of side effect, and some of that is due to the slow or fast absorption and how quickly things are metabolized. So I kind of wanted to show that a little bit. All right, here's our references, and I just want to say one more time that, you know, these facts and these things we're learning in this class, it is really important to kind of have a base for understanding of these. And if you have a client who comes in and talks about either wanting to get on medication or current use of medication, and you know what they're taking, you have, you know, the knowledge to at least go and say, okay, I know some of this, but let me look up this specific medication and read about the side effects of this so I can kind of understand my client's subjective experience. And then you can help advocate and say, hey, you may need to go talk to your doctor. That sounds like that's a pretty miserable experience, and those side effects are really hard to live with, and you can really support your client. We never, ever, 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 ever want to give medical advice. All right, thanks for listening.